All right, everybody. Thank you very much for coming to the Teaching Nephrology Providers New Tricks in Diabetic Kidney Disease session. My name is Alex Chang. I'm an associate professor at Geisinger Health.
Hi, I'm Leka Tamilapalli. I'm a nephrologist and health services researcher at Cornell.
And we have a great lineup today of speakers talking about gaps in care in diabetic kidney disease, how decoding diabetes management in the modern era, and clinical decision support to enhance guideline-directed medical therapy. So I'm going to invite the first speaker up, Dr. Jungyim Shin. She's a physician, a cardiologist, PhD-trained pharmacoepidemiologist, and associate professor in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. She's a core faculty member of the Welch Center of Epidemiology, Prevention, Clinical Research, and her research focuses on comparative effectiveness and safety of anti-diabetes medications, post-marketing drug safety in chronic kidney disease, and disparities in healthcare utilization, including pharmacologic agents.
Hello, everyone. It's a very, very pleasure to be here today. So as Alex mentioned, I will talk about what we know about how the life-saving guideline-directed medical therapy is adopted in DKD population. So these are my disclosures. So today, this session's objective is to understand a very brief epidemiology of diabetic kidney disease, DKD, and I also would like to describe what is the GDMT in this population. And lastly, I will talk about current gaps in adoption of GDMT in this population. So 14% of US adults are estimated to have chronic kidney disease, which means about 36 million people have CKD in the US. Approximately 1 in 3 adults with diabetes may have chronic kidney disease. So this is a pretty common condition. How about globally? So this figure is from a global burden of disease, and this figure illustrated number and rate of disability-adjusted life years of CKD in 1990 and 2017. So DKD, and then each color represent different codes of CKD, and red color indicated type 1 diabetes, and the orange color indicate the CKD due to type 2 diabetes. As you can see, just visually, a burden of burden of CKD due to diabetes increased a lot over time. And let's go a little bit detail. DKD accounts for about 31% of CKD deaths, and this is the largest contribution in terms of absolute deaths of CKD in any cause in 2017. This resulted in 11 million deaths of CKD. And type 2 diabetes, as I mentioned, was only cause of CKD to show significant increase in the age standardized deaths rate by 9.5% between 1990 and 2017. This is another GBD study. So between 1990 and 2012, the number of deaths attributed to DKD rose by 94%. And this the table is a little bit updated GBD study. So these are the list of leading cause of deaths in 1990, and also right column is leading cause of deaths in 2019. So back then, 1990, the diabetes was ranked as 14th, and CKD was ranked as 18th. However, 2019, it jumped a lot. So diabetes ranked as 8th place, and CKD is ranked as 9th place. So the burden of DKD is increasing globally as well as in the US. So I don't have to talk about why this is important in front of a lot of nephrologists here. So we need a comprehensive care to protect kidney and heart in diabetic kidney disease population. This pyramid illustrated how we can do that, and according to the KDIGO guidelines. So of course, we have to do like a lifestyle and then self-management, so including healthy diet, exercise, smoking cessation, and then optimal weight management. And then first-line therapy include metformin, as well as SGLT2 inhibitor, RAS inhibitor, and statin. And in order to protect further, if there is residual risk, we can consider GLP-1 receptor agonist, and then antiplatelet therapy, as well as non-steroidal MRA. Among all these components, and ACE or ARB, SGLT2 inhibitors, GLP-1 receptor agonists, and non-steroidal MRA are increasingly recognized as the pillars of CKD therapy in patients with diabetes. So I will talk more about these four therapies. So ACE or ARB, I think it has been a decade, right? It shows like a delay, the CKD progression, particularly when albuminuria is present, and they reduce cardiovascular events, and then cardiovascular and mortality benefit persist regardless of albuminuria level in people at high cardiovascular risk. So therefore, guidelines recommend ACE or ARB to be initiated in patients with diabetes, hypertension, and albuminuria, and these medications should be up-titrated up to the highest tolerable dose. It is important to note that for patients with diabetes and albuminuria, even normal blood pressure treatment with ACE or ARB can be considered. Let's talk about some new medications. So this data is meta-analysis of randomized clinical trials of SGLT2 inhibitors by diabetes status. So SGLT2 inhibitors, as you know, that this is developed first for the diabetes, but now it can be used for non-diabetes population as well. Since today's talk is focusing on diabetes populations, let's look at the diabetes result. Here, the SGLT2 inhibitor reduce the risk of CKD progression as well as AKI as well. SGLT2 inhibitors also improve the heart outcome, particularly for heart failure. So here, composite outcome of cardiovascular death or heart failure, relative risk reduction was about 21%. And then also like heart failure and the mortality, it reduced the risk of mortality by about 12%. Based on this overwhelming evidence of clinical trial, now guidelines recommend like SGLT2 inhibitors for patients with type 2 diabetes, CKD, if their eGFR is greater than 20. The reason we have this eGFR greater than 20 is clinical trial, they did not include patients below eGFR less than 20. However, we learned from the past, right? So like before ACE or ARB, whether like we should discontinue or continue when their eGFR below 30, because like a clinical trial couldn't answer this answer, there was a lot of problem with that. So we didn't want to like repeat that part. So clinical trialists, they continued like the SGLT2 inhibitor during the course of therapy if their eGFR dropped 20, and then they show the benefit of the treatment. So guidelines recognize do not initiate the SGLT2 inhibitor when their eGFR is greater than, lower than 20. However, if during the course of therapy, if they drop, they can continue. And also they guideline recognize these medications should be prioritized for patients with ACR greater than 200, as well as people with heart failure, because the benefit is, heart failure benefit is larger with these SGLT2 inhibitors. Let's move on to the GLP-1 receptor agonist. So again, GLP-1 receptor agonist started from the diabetes as a diabetes drug. Now it is approved for the obesity management as well. So this meta-analysis shows that a consistent benefit of GLP-1 receptor agonist on cardiovascular outcome. So it reduced the risk of major adverse cardiovascular event. The relative risk reduction is about 13%. And then it reduced the risk of non-fatal myocardial infarction. Relative risk reduction is about 10%. And consistently cardiovascular death and then non-fatal stroke, like all, it is reducing about like a 13%. And GLP-1 receptor agonists also reduce the risk of heart failure and also mortality in diabetes population. Lastly, including most recent trial of flow trial, and this meta-analysis showed that GLP-1 receptor agonists improved the kidney outcome in diabetes population. So there are overwhelming evidence. So the KDIGO guideline recommend in adults with type 2 diabetes and CKD who cannot achieve their glycemic target despite the use of first-line therapy, it's called like a metformin and SGLT2 inhibitors, or those who cannot use this medication, long-acting GLP-1 receptor agonist is recommended. So GLP-1 receptor agonist is considered as additional risk-based therapy, and this GLP-1 is preferred over insulin initiation. However, it is important to recognize current KDIGO guidelines do not yet reflect 2024 data from the FLOW trial. So FLOW trial, they examined the effect of semaglutide weekly injection on kidney outcomes in patients with type 2 diabetes and CKD. This Kaplan-Meier curve shows that the semaglutide compared to placebo reduced the risk of the kidney event by about 24%. So most recent, like the 2025 American Diabetes Association guideline, also KDIGO agrees. So semaglutide can be used as another first-line agent for people with diabetic kidney disease. Lastly, the finerenone. So this finerenone, this result is the combined pooled analysis from 2 trials of finerenone. So finerenone is currently only like a non-steroidal MRA, which has cardiovascular benefit. So as you can see here, the composite cardiovascular outcome, as well as kidney outcome, depending on how the eGFR decline is defined at the end. The magnitude of effect size is slightly different, but it shows the reduced risk of CKD progression, also death from any cause. So based on these results, a guideline recommend non-steroidal MRA, which is right now like a finerenone is the only medication. And for those with type 2 diabetes and eGFR greater than 25, and their serum potassium should be normal, and then albuminuria greater than 30, despite maximum tolerable dose of RAS inhibitor. There are also potential benefits of combination therapy through both shared and distinct mechanisms. So this combined therapy becoming more and more like a standard of care in clinical practice. However, historically, it takes about average 17 years to move new treatment from clinical trials to daily practice. It takes very, very long. And so, I want to share how we are using this life-saving medication for our patient population. So this is a study from the QRCKD registry, which is an EHR database from Providence and UCLA healthcare system. They included about 40,000 patients with DKD with at least 90 days of follow-up. And so what they found was ACE or ARB use at baseline was 70%. And SGLT2 inhibitor, GLP-1, use was very, very low, 6% and 6.8%. They also examined the persistent prescription, at least 90 days, and it dropped a lot significantly, even for ACE inhibitor ARB, and 40% only persistently prescribed ACE or ARB, and SGLT2 inhibitor and GLP-1, it was 5% and 6%. GDMT prescribing rate was very low, but look at here, this is a little bit old, like a 2019 and 2020. And another study, I think this study is also very important. So they look at how many people they initiate ACE or ARB after diagnosis of CKD. So when they were diagnosed with CKD among patients with diabetes, most of them are already on ACE or ARB because of hypertension control and other stuff. So 70% they were already on ACE or ARB. However, those who are not on ACE or ARB at the diagnosis of CKD, only 17% initiated ACE or ARB within a year after diagnosis of CKD. This is our own data. So we examined over 3 million people using Optum Labs data warehouse data, and this is nationwide EHR data. And our study period is a little bit more recent, 2022 and 2023. So see how we can do better compared to before. And this like a complicated like a Venn diagram is because we included both diabetes and non-diabetes. But if you look at only diabetes population here, orange circle, so this is a DKD patient. So regardless of so people with diabetes and CKD only, about 13% were on SGLT2 inhibitor. If they have additionally ASCVD, 12%. If they have also heart failure, 14%. So like the number of comorbidity really didn't matter. All diabetic kidney disease patients, about less than 15% were on SGLT2 inhibitors. And ARB use was about 60%, a little bit much better, but we can do better, I think. And we also look at the variation across health systems. So if you look at the left column, which I circled, this is diabetes with class 1 recommendation for SGLT2 inhibitors, which include CKD, heart failure, and ASCVD. And there are significant variation across health systems. However, if you look at there, almost all the systems, 28 health systems, none of them prescribed SGLT2 inhibitor above 25%. All of them less than 25%. So like even though there is some system is doing better and some system is doing worse, but overall, all the systems are using SGLT2 inhibitors suboptimally. We also look at who is prescribing these medications. And so like focusing on this diabetes population, most of the SGLT2 inhibitor prescription came from primary care physician, and then followed by endocrinologist, and followed by the cardiologist. And then contribution by a nephrologist was pretty small in this setting. It's only about 3.6%, mainly because these population received care from the primary care doctor mostly, because like until they reach the advanced CKD, they don't see the nephrologist. And this study is like very interesting. So they look at, using VA data, they look at whether SGLT2 inhibitor prescription was higher among those with albuminuria. They are supposed to be higher. But interestingly, both SGLT2 inhibitor and GLP-1 receptor agonist use was less frequent for those with a higher albuminuria level. They also look at the prescription pattern by ASCVD risk and then ESKD risk. And again, this is odds ratio for each medications. And as like the risk goes up, paradoxically, the use of SGLT2 inhibitor or the GLP-1 receptor agonist was lower. This risk treatment paradox has huge implication because we know the relative risk reduction of these medications are similar across the risk category. However, the absolute benefit is much larger in high-risk population. So if we are not giving this to the high-risk population, I think we are not maximizing the benefit of this medication in the population. Similarly, we conducted another study using Optum data, and this was like look at here, we look at the prescription rate of SGLT2 inhibitor and GLP-1 across CKD risk categories and also across patients with and without cardiovascular disease. And this look complicated, but the height is very similar, right? So regardless of CKD risk categories or presence of cardiovascular disease, prescription rate was pretty similar. So that means that we are not targeting toward high-risk patient. And so this one is like the finerenone use in real world. We are working on this, and this is preliminary result. And one single health system, we looked at it among about 20,000 patients with diabetes eligible for finerenone, meaning eGFR greater than 25 and ACR greater than 30, only like the 0.26% of patients initiated finerenone. So extremely low uptake of finerenone. And, but interestingly, among finerenone users, when we look at the CKD progression risk, actually it's very targeted for the high-risk patients. So compared to other GDMT, like a GLP-1 and SGLT2 inhibitor, this finerenone was more targeted toward the high-risk patient. So, in conclusion, like the 1 in 3 adults with diabetes may have CKD, and global burden of CKD is increasing. We have now multiple effective therapies, including ACE, ARB, SGLT2, and GLP-1, and non-steroidal MRA. And combination therapy of these agents potentially offer additive benefits and is rapidly becoming the standard of care. And clinical guidelines are very clear. I think they say what patients should receive in certain conditions. However, adherence to these guidelines and translation of findings from clinical trials are suboptimal. So we really need to close these gaps between what we know and what we do. I think our next two speakers will talk about more about this. Thank you.
Thank you very much, Dr. Shen. If anybody has any questions, please feel free to step up to the microphone.
Hi, I'm Bhavna Chopra from Beth Israel Deaconess. Great talk. I was wondering, in all your data where you look at the prescription patterns, do you include patients who we prescribe the medicine but insurance doesn't cover and the patient not able to take it? I mean, I have a good number of people who we really want them to get it, but we just can't get coverage. So did you include that in the studies, or these are the people who are only getting the medicine?
So like these, the one we studied, we included those have insurance as well as no insurance. Like it has like a commercially insured people as well as Medicare, Medicaid uninsured people. We didn't particularly look at individual level of like insurance data, whether that is associated with use of like this GDMT, but there are tons of data outside there. Like access is huge issue. Those who have like a less no insurance, and they are less likely to get these medications. And then interestingly is like what we found is the hospital level, those who have a lot of people who have more people with like no insurance, they are less likely to prescribe. So in the hospital level, I think that makes sense too, right? So we took a look at it. Yeah.
Thank you.
That's very important aspect, access to this medication.
Hi, thank you. I have a question. Do you see in your data if there is any trend in the prescribed by primary care doctors? Because we have analyzed some data, local data in Florida, and we see still this medication are being prescribed by specialists, nephrology, cardiovascular doctors, and endocrinology, but still the uptake by primary care doctors is not happening.
Yeah, so in our data, we didn't look at the particular trend, like who is like a trend of prescriber. We only look at the most recent data. And yeah, we didn't look at, but that's a very good point. But I think like here, the issue is like especially like the advanced CKD patient, they are seeing multiple patients, right? The nephrologists, cardiologists, and primary care. So I think care coordination is also very important across different specialty. I think sometimes like who should prescribe, who should initiate this, like the medication is complex issue. So I think very fragmented care is also a big problem in terms of like the increasing this type of medications.
Thank you.
One more question. So how has the uptake compared to some of the other cardiovascular renal drugs in the past that after they've developed an indication, are you seeing similar trends as the other ones, or?
The other one means like?
Like when ACE and ARBs came onto the markets, for example.
That's a very good question. I think I cannot think of like the direct comparison directly right now, but I know like the ACE or ARB has been here more than 20 years, like, right? But still, like in our data, it's like a nationwide data, only 60% are on it. So like after 20 years, we know like ACE or ARB is protecting kidney and heart, but only 60% are getting. I think that's a huge problem. I think in order to reach like now, like SGLT2 and GLP-1 and finerenone and all these medications, like a blockbuster medications are here. And if it takes like the 20 years, 70 years, I think we are like we are losing a lot of opportunities, right? I think we really have to do a better job in terms of like putting this medication on our at-risk population.
Thank you, Dr. Shin. I think that's a perfect segue, because now we'll have Dr. Rosas that will show us how to do this.
Yeah, great. So we're very pleased to welcome Dr. Rosas. She's a nephrologist, epidemiologist at Joslin Diabetes Center and associate professor of medicine at Harvard Medical School. Her research focus is on the epidemiology of diabetic kidney disease. She is really one of the international experts. She's also evaluated health disparities in individuals with CKD, particularly those of a Hispanic Latino background, and she's also the PI of the Apollo study as well as the Kidney Precision Medicine program. She received numerous awards, including NKF New England Physician of the Year, and she was also president of the National Kidney Foundation. So really looking forward to your talk.
Okay. So good afternoon, and welcome to this session, and thank you for the organizers for inviting me. And I'm going to talk a little bit about diabetes. These are my disclosures. For this talk, I have to say that I am in the steering committee for the FIND-1 study, which is finerenone in type 1 patients. So I will discuss a little bit about that. And you already heard that I was the past president, and I have a little small advisory role for Novo Nordisk. Anyway, so I'm gonna try not to repeat what was said in the previous talk and focus on things that have not been mentioned, but there might be a few slides that might be repeated. But let's start with the burden of diabetes, and I bring this picture from Dr. Tuttle, where she talks about 95% of most people with diabetes have type 2, but there's still a big percentage. 27 million people in the world have type 1 diabetes, and so we should not forget about them. That's point number one. And point number two is that we do have concerns about kidney failure. We're a nephrologist or in the nephrology area, and so we are, for us, obviously, kidney failure is a failure, and therefore we want to prevent that. But it's also very important to know that our patients are suffering from cardiovascular disease, and 9 out of 10 will die before they reach kidney failure, and so that's why cardiovascular disease is so important to treat. So here is really an old slide. It's about 10 years old now, but just showing the relationship with eGFR and mortality. And see, it works. Okay, so here you can see this is our dot for GFR, and you can see that both all-cause mortality and cardiovascular mortality starts peaking up as your GFR declines. And also highlighting the linear relationship between albuminuria. So we use this arbitrary cutoff of 30, but just reminding you that 5 is better than 10, and 10 is better than 20, and 20 is better than 30. So we should continue, it's a continuous line, and lower is better. So we all know how to screen for kidney disease. The guidelines say if you have type 2, you should screen immediately for kidney disease because up to a third of individuals at the time of diagnosis of type 2 diabetes, they already have kidney disease. They already have albuminuria. They already have low GFR. So that's why it's important to screen at that time. And also in individuals that have type 1, we do have some leeway, and the current guideline is it's okay to wait 5 years from diagnosis because the time of diagnosis of type 1 is more, let's say, certain. And we already know that screening, you need both the urine ACR for albuminuria and a creatinine to measure eGFR. So why is this so important? And this is the reason. So you can see that if you have low GFR, you diagnose 21% of individuals with chronic kidney disease. But if you do not measure albuminuria, you're missing this 22% of people here that are high risk for kidney failure, cardiovascular disease, mortality, that you are not screening. So half the people with type 2 that have chronic kidney disease really only, let's say, have high albuminuria. But that high albuminuria still puts them at high risk for cardiovascular disease and kidney failure. Okay, so here's just an example, multiple studies. This is one of them. The big boxes are health systems with more than 50,000 people, little boxes, less than 5,000 people, just showing you that because creatinine comes in the regular, Chem6, Chem7, basic panel, et cetera, it's very common for patients with diabetic kidney disease to have at least one measurement of eGFR a year. That's what this shows. So everybody sort of passed, more than 90% of individuals get that. That doesn't mean that they're acting on it, but that's showing that it at least was measured. However, the urine ACR, apparently it's very hard to get people to be in a cup, and so only half of the people. You know what's so sad about this is that like 70% of people get a colonoscopy. To get a colonoscopy, you have to make an appointment. You have to go get the Go Light or whatever you're taking. You have to go home and have a liquid diet for 3 days. Take the liquid diet, right? Then go and have the colonoscopy. Have somebody pick you up and have it. And that we can do in 70% of the people, but we cannot get half the people to get a urine ACR. That's what's so sad about this. But anyway, we keep trying and highlighting and remembering that this all needs to be done. Because if they can do it for colonoscopy, we can do it for UACR. Okay, so this is just to highlight that diabetic management is a team sport. It really, the glycemic management is very important, the blood pressure management is very important, lipid management is very important, and I'm gonna discuss a little bit about the cardiovascular and kidney protection medications. But again, lifestyle modification is vital, and every time we see our patient, we should insist on quit smoking, how much are you walking, how is, walking the dog, chair exercises, whatever it is, to sort of modify that lifestyle, like more plant-based protein diet, etc. Anyway, in the past, we used to focus on hypoglycemic effect of certain medications. Now, as was discussed previously, we have a gamut of medications. I'm going to be discussing more the SGLT2 and the GLP-1s because, as was mentioned, they have both effects on progression of chronic kidney disease and cardiovascular disease, both atherosclerotic vascular disease and heart failure. The SGLT2s more on heart failure, the GLP-1s more on atherosclerotic disease, but also we need to remember that they, as was mentioned before, they're a little bit more expensive, or a lot more expensive, and they have a higher a burden to prescribe, but we need to make the effort. So a few words about glycemic control. So we're all very impressed with how these medications work, but I have to remind you that glycemic control works very well too. So if we get our patients on glycemic control, we can get 34% reductions, 43% reduction in the risk of kidney failure. So it's not something that we need to forget, let's say. I was going to talk a little bit about CGMs. That's the continuous glucose monitoring. They come in multiple shapes, let's say, and the most common ones are the Libre, which are the little scent one that people put in the back of their arm, or the Dexcom level 6 or 7. Those are the sort of more popular ones. But I just wanted, this is like CGM 101 but it's important that the patient wear it. That's number one, right? So you cannot, you can prescribe it, but if they're not using it, at least it's recommended for 14 days before you print it out. And that they have to have it on 70% of the time. So if they had it on and then it fell off on the third day, that's not a good reading. And then I will go over the printout, but these are sort of the terms that we need to start getting more familiar in. The first one is TIR, which stands for time in range. And we want people to be 70% of the time in range. And then there's levels of hyperglycemia, level 1 and level 2, that's just based on the level, and then levels of hypoglycemia, and now levels less than 55, or 54 or less, are the ones that are considered hypoglycemia, like severe hypoglycemia, and that need perhaps assistance. So here is these are the time in range that are recommended for both patients with type 1 and type 2. These may be different if you're older or you're pregnant, et cetera, where you can be a little bit more permissive. But for most patients, you want them to be in range, which is 70 to 110, 70% of the time. And so anything more than, 70 to 180. And anything more than 180 is considered hyperglycemia, and there you have the target, and you would prefer less than 25% of the time. And of course, we don't want our patients to be too low, and any hypoglycemia more than 4% of the time is not considered appropriate. These are all computerized, and it tells you what they call the GMI, which is sort of a measure of variability. And here is one of the ambulatory glucose profiles. It's a very useful tool. In the top, you can see the first one is the average. This is an example. The average glucose, and then they estimate what the A1C would be based on what the algorithm that they have. And here you can see the time in range. So in this patient in particular, it was 54%. So this person is not meeting the goal. And then below, you can see sort of the range in the whole 14 days. Let's say this person had it for 14 days. Here it says they were active 70% of the time, so it would be a valid reading. So here you see what this person's readings would be. On average, it does look like this particular example would go higher in the afternoon. And then you can see below on daily what the readings were for each person. And so then you can help the patient have better control. This is another brand. That's the reading for somebody, another brand, but it's very similar, as you can see. So for many years, we had very little, let's say, I don't know if the word is movement, but very little new medication. We were doing all these studies that were negative for the treatment of diabetic kidney disease. Then all of a sudden, we have a plethora of medications, so we're all very grateful for that. And anyway, so RENAL, were the ARB trials, RENAL and IDNT, they showed an improvement in at that time we were using doubling of serum creatinine, which is about 57% of reduction in GFR, kidney failure or death. But you can see that both losartan and irbesartan had a risk reduction that was high, but there was still a significant risk for kidney failure. This is a recent study from Dr. Koo that basically shows that they combined 17 trials of RAS blockade and tried to look at that dip that we all see when we start RAS blockade and which dip was the most beneficial. In their studies, they showed that initially in the first month, a dip up to 21%, that's the number they had, was still appropriate and beneficial, and over 3 months that dip would improve, and they used 13% as the beneficial number, let's say. I just want to give a little plug to the patients with normal albuminuria because we talk a lot about albuminuric patients, but I want to highlight that our patients with normal albuminuria also progress, not at the same rate, but still high, 1.9 a year. Those with microalbuminuria, 2.3 mLs per year, and of course the ones with severe albuminuria have the highest progression. So the same very similar numbers for type 1 and type 2 diabetes. So while again, we focus a lot on urine ACR, and those are the people at highest risk. I don't want you to say, oh, well, this person doesn't have albuminuria, let me not give them SGLT2s or GLP-1s, et cetera, because they would benefit from them. So these are just reasons why you would, if the person is not seeing a nephrologist, you would consider a person having non-diabetic kidney disease and perhaps needs a referral to nephrology. I discussed about, a type 1 patient that at the time of diagnosis also has kidney disease. It's likely not type 1 diabetes. If they have an active sediment, if they have really chronically well managed, we see our patients that are like 6.5, 6.5, 6.5, all of a sudden they have albuminuria, all of a sudden they have a decrease in GFR, that person really needs to see a nephrologist. Perhaps they need a kidney biopsy. And particularly in type 1 patients, if they do not have retinopathy, it's very unlikely that they have a chronic kidney disease due to diabetes, although I have to say that I have biopsied plenty of them and they have diabetic kidney disease, but the current language, let's say, is that we would biopsy those patients. So here's the 4 pillars. I'm not going to go over them because they were just mentioned in the prior talk, but we have RAS blockade, SGLT2, finerenone, and GLP-1s. Here are all the SGLT2 trials. The first one is Credence, DAPA-CKD, and EMPA. They have different populations. Credence recruited individuals greater than 30 years of age, all had type 2, all had severe albuminuria, and I have highlighted for you here at the bottom the GFR, the ACR, and the percentage of individuals on RAS blockade in each study. So you can see that in Credence, they had the highest GFR. They all had to have severe albuminuria to enter the study, and they all had to be on RAS blockade. But the RAS blockade could be any dose. You could be on 2.5 of any medication and still make it to the SGLT2 trials. So DAPA-CKD only had 2/3 of the individuals. So we learned a lot about non-diabetic kidney disease. The GFR threshold came down, but they also only recruited individuals with severe albuminuria. And then EMPA kidney came, and with the threshold again lowered for GFR, and they recruited individuals with no albuminuria. So we learned about the effects of SGLT2 in non-albuminuric patients, and they were also including even more patients without RAS blockade. So these are studies that cannot be compared to each other, but these all together teach us a little bit more about how to use SGLT2s. This is the dip again, and just showing, this is in the DAPA studies. The top panel is DAPA, the lower panel is placebo. You can see that whether you have a dip or not, in the placebo you did just the same. But in DAPA, if you were taking DAPA and you had a dip, which is the lighter gray here, your progression was more favorable. So you had the least progression compared to the other ones that had no dip, or actually the GFR went up. So now we go to GLP-1s. And we all love that the FLOW study was positive, and we're very happy that it has now an indication for chronic kidney disease, but we're still a little bit perplexed of why it exactly works. The glomerulus has in the afferent arterial is the only, one small section of it in the vascular smooth muscle is the only section that has GLP-1 receptors. The rest of the kidney does not have GLP-1 receptors, so how it works in the kidney is unknown, but all the studies have shown that it decreases albuminuria. All of them have shown that it increases natriuresis, and that now we have the FLOW study, which showed that it's protective of the kidney. So this was the FLOW study. It was, you can see here, the inclusion and exclusion criteria. They used dose escalating, 0.25, 0.5, and then 1, trying to use sort of a kidney protective dose that was not hopefully losing weight, because we always have that issue with when patients lose weight, their creatinine goes down, they lose lean body mass, and so they didn't want this to be sort of a weight loss trial. They wanted this to see if it was protective of the kidney. So the trial came out and it was positive. Here I show you what I've been showing you all along. This is the GFR, the ACR, and the percentage of people on RAS blockade. And you can see that there was an improvement in individuals that were on semaglutide. They have a 24% risk reduction on the kidney outcomes, both when they include cardiovascular death, which is panel A, or without cardiovascular death, which is just the kidney-specific outcomes. So they were both positive. However, the individuals did lose weight. So on average, it's not tons, but they lost 9 pounds. Their A1C did get better by 0.8, and they did lose 2 points, 2.23 milligrams of mercury for blood pressure. There have been studies trying to do this mediation analysis to see what was the benefit, and there's been some data that perhaps even the 2 points in blood pressure control may contribute to the improvement. But anyway, the study is positive, and this is an accumulation of the SUSTAIN 6 and the PIONEER 6 study. These were studies that were done actually for the glycemic and cardiovascular outcomes. But you can see here, this is looking at the kidney outcomes from those 2 studies combined. It includes the oral and the injectable. And you can see that regardless of your A1C, you would improve if you were on the study medication compared to placebo. So the gray is placebo, the blue is the active medication, semaglutide. And so whether you have whatever your range of A1C, whatever your weight, your UACR, there's improvement when you take the medication compared to placebo. Now I'm moving on to finerenone, and this was discussed previously. I think she presented data on Fidelity. Fidelio was the kidney outcome trial for finerenone. It has individuals, the average GFR was 44, everybody had severe albuminuria, and different from the SGLT2 trials, they all had to be on maximum tolerated dose. So it was not a little bit of RAS blockade, it was maximum tolerated dose of RAS blockade. And that's the difference between the Fidelio or all the finerenone trials and the SGLT2 trials. So all the outcomes were positive, but finerenone does cause hyperglycemia. And there is a 0.2 increase compared to placebo. But in the trial, only 2.3% of the individuals on the active arm had to stop the medication because of hyperglycemia, compared to 0.9 in the placebo arm. So it's still, it is something that has to be monitored, but it's not an overwhelming adverse event. I wanted to mention some things that are coming up, and we saw this presented 2 years ago, the Senate CKD trial, endothelin receptor antagonist, and SGLT2. I think we're going to see a lot more of these. We're going to learn how to use them. They're not FDA approved yet, but here you can see in this one, it's called Sibutitan, but there are others also in the market, and it's made with AstraZeneca, so that's why it has DAPA. But anyway, so they compared just DAPA by itself, which is the red, and Sibutitan plus DAPA in different doses. Because you remember that the side effect of endothelin receptor antagonists, which had been tested in the past, the problem was that everybody got edema, right? And there was more heart failure. So when they combined the medications, you can see that there was a benefit, and they didn't have the same effect. So combining this is a urine ACR, so there was a decrease in albuminuria with just DAPA, but an increased benefit from the combination. So I think that's where we're headed. We're headed to trying to learn how we use these medications in combination. This is the BI 690517, which apparently now has been baptized as Vicadrostat. And here you can see same thing. This is a different company, and so they use empagliflozin and with them, and you can see that when you combine it and use different doses, you can see a benefit there. When you're with EMPA, it's 51, I'm sorry, the C is without EMPA, the 51%, and then when you combine it with EMPA, it goes up to 70%. So here is DAPA with GLP-1s. This study was done before our more modern GLP-1s were, so this is exenatide, which really is not used right now, but the dark blue is the combo of the GLP-1 and DAPA, and you can see that they have the highest decrease in albuminuria, and here each one alone. The gray is exenatide and the light blue is DAPA. So in combination, it's higher decrease of albuminuria. It's also a highest decrease of GFR. So particularly if you use cystatin C. So here's the ROTATE trial. They had only 46 patients, but they randomized people to just DAPA, eplerenone, or eplerenone and DAPA, but it's the same patient doing it themselves. And so you can see it was 4 weeks in each treatment. So each individual contributed to each bucket, let's say. So you can see that the UACR change from baseline, again, was higher when you combine DAPA and eplerenone. And something else that we learned, that we had learned from the Fidelio trials too, was that the individuals that were on SGLT2 were protected for hyperkalemia. And you can see that here, that eplerenone went up by 0.36. The DAPA didn't have much change in the potassium, but if you combine them, it was only 0.2. This is the confidence trial, so finerenone and EMPA, finerenone alone with placebo or EMPA with placebo, and the goal is to look at the combination of finerenone and an SGLT2 will protect the kidney or not. Those results will be presented at the ERA in May in Vienna, and then at the ADA in Chicago in June. So then I wanted, again, to highlight a little bit of the things that we're doing for type 1 patients. Type 1 patients, in the past, we believed that they were totally different people, but we know that our type 1 patients are not as skinny as they used to be. That were type 1 patients are also not as young. I mean, we still have the young, but now we're diagnosing type 1 because we have more tools, et cetera, in the elderly. So I think we're revamping who has type 1 too. But anyway, so type 1 and SGLT2s. So in Europe, the SGLT2s have been approved for patients with type 1 if you have a BMI greater than 27. But in the United States, that has not been approved. And part of the concern is that this is data from type 1, the studies on type 1 patients that used SGLT2 inhibitors. You can see that it's a moderately effective decrease in A1C, and there are all the studies. So like 0.4, 0.5, that's sort of where they hang. And here you can see that the other effect that it has is a decrease okay, so here's EMPA, the different doses of EMPA, and I'm trying to read oh yeah, this is the change in urine albumin to creatinine ratio. So you can see that it works. So it not only decreases glycemia, it also decreases albuminuria in type 1 patients. SOTA is one of the medications that is both an SGLT1 and an SGLT2 inhibitor, and all their studies have also shown what I just told you, the usual eGFR dip and the usual decline in urine albumin to creatinine ratio. So it works in type 1. The problem is, this is real life evidence of a registry in Europe, and these are the patients that were taking the medication, and you can see that they had a significant protection and a decrease in urine albumin to creatinine ratio. But now here's the problem, that there are an increase in DKA. So I'm not going to talk about genetic infections, et cetera, but the reason it hasn't been approved in the US is because they have, in this case, this example, at 7 DKAs, particularly at the higher dose of SGLT2s. And so that obviously is a concern because safety is a concern. But when you look at it, the risk of a DKA is about 0.04, about 1 to 2%, but the risk of death when you have a DKA is about 0.04. So there is a risk of death, and that is the problem. But the risk of cardiovascular disease and kidney failure is very high also in type 1 patients. So here's that table where I was showing you the risk of death of 0.4 and the risk of hospitalizations for DKA that was a 1.2. So this is what the FDA said, that there was going to be increased death due to the use of SGLT2s, and that's why it's not approved. I'm going to skip over this, but in summary is when you start the SGLT2, you decrease the glucose, your insulin requirements are less. That leads to lipolysis. That also increases your glucagon, and both act on the liver to increase ketogenesis, and that's how you end up with ketone bodies. And so there is now a protocol to decrease ketogenesis with SGLT2 inhibitors, and we all know about it. No fasting, no dehydration, no ketogenic diet, decrease it if you're gonna have elective surgery. And now we're fortunate that we have the point of care measure of ketone bodies. So there's the STITCH protocol, which is if patients are in trouble, it's stop the SGLT2 inhibitor. The I is for inject insulin, or insulin, I guess. Then the CH is for the carbohydrates, and then hydrate is the H. And so because there's this dichotomy that, okay, our patients at higher risk of kidney failure, what is worse, to have a DKA episode, or is it worse to end up on dialysis? We are trying to perform a study that is called the sugar and salt. And so these are all the sites. There are about 12 sites in the US and six sites in Canada. And of course, Boston is included, but if you're living in one of these areas, please feel free to refer your patients for the study. And it's really look at the effectiveness of sotagliflozin, but it's more about implementing a DKA mitigation protocol to see if we can give this medication safely to patients with type 1, giving them a ketone body, giving them education, and also a way to measure their ketones at home so that if there is a concern, they can be measuring it. So 150 patients will be recruited. They will get SOTA, and it's a 3-year follow-up, and hopefully we already started recruiting. We have few patients, but obviously we still have ways to go for recruitment. The other study this next study I'm going to talk about is the FIND-1 study. This study already finished recruitment. So in this study, individuals are being randomized to, this is also type 1 study, individuals are being randomized to finerenone, or 10 or 20, depending on their GFR, same as Fidelity or Figaro, or placebo, and they were followed for 6 months, and the outcome is the decrease in UACR in those 6 months. Because it's being used as a bridging biomarker. We have all the physiology. We know that DKD is a problem. You have more albuminuria. So the FDA has agreed to give an indication for type 1 patients just using albuminuria. So we are excited about that, and those results we are hoping to present in November at the ASN. So this was really fast, but I'm still on time. But just wanted to highlight that we talk a lot about the pillars of therapy, and the pillars include the initial, like I said, like the glycemia, the blood pressure, that's still a pillar, the lipids, and then the agents. The agents are one of the pillars, and then in those, we can have all the medications that we have right now. Here it's more of what I told you. I think that we are at a stage that we really should be talking about preservation of kidney function. We should be in the preventive nephrology type area, borrowing from our cardiology friends. We should be promoting kidney health in all of our risk individuals. We have to remember, and actually that's why I love coming to the National Kidney Foundation meeting, because we understand that this is a multidisciplinary team. We need our nutritionists, we need our social workers to help us look at the social determinants of health, because without good glycemic control, et cetera, we cannot do this work. I also wanted to make sure that you guys keep updated with the guideline-directed therapy, because it's changing really fast, and so, you know, just take a look every once in a while to see what has changed, or come to the NKF and we will let you know. So this is my email and my Twitter if you want to contact me.
Wow, that was an incredibly informative talk. Thank you, Dr. Rosas. We have time for maybe one question. If someone wants to come to the mic.
So so I have personally not prescribed it, but if they have obesity, they meet criteria, and I do have patients that have type 1 that are on GLP-1s. So they are being used, and they're same as in type 2, their insulin dose is reduced.
Any concerns about safety?
About what, I'm sorry? Safety. No, so far, no issues. I mean, they have the same side effects, right? Like the GI symptoms, et cetera, yes.
Bessie Young, University of Washington. I believe albuminuria is not a HEDIC measure. Am I correct? And so primary care providers, as you said, don't actually screen for albuminuria. Should we try to get that changed? Because we are missing patients in primary care. They're not getting put on medications, and then they come to us with creatinines of 3, and it's too late.
So actually, it is a HEDIS measure. So I would say like since 2021, I think, right? It is, Leica, you can tell us about how it went. She worked a lot on that. But it's what do we call it? The kidney
Evaluation measure.
Okay, evaluation measure. So you have to, if you have diabetes, you have to have both the GFR and the albuminuria. And I would say it has improved. I think before we did it, it was like 30, and now that we're on 50, so we're calling it success. But I always give that example of the colonoscopy, because I'm telling you, I don't know how we can get all those procedures done for colonoscopy and not get the urine ACR. So I think we can get it done. We just have to be mindful to ask for it.
Great, well, thank you.
Wonderful, and I think that leads us very well to Dr. Wilson. He's an associate professor of medicine and public health at Yale University, director of Yale's Clinical Translational Research Accelerator. He uses the tools of data science, machine learning, digital health devices, epidemiologic and translational research methods to target diagnostic and therapeutic interventions to patients at the point of care. His particular interest is in making care delivery more efficient by using data science approaches to target interventions to patients most likely to benefit. These models can reduce the number of individuals exposed to a drug or intervention, unnecessarily reducing adverse events and lowering costs.
Thank you. Hi, everybody. Thanks to Alex and Leica for having me here. And thanks to my co-presenters who gave me quite an education on diabetic kidney disease. This is not exactly my area. Those of you who know me know I'm more of a AKI researcher and sometimes a digital health researcher. And I'm going to talk to you about clinical decision support. So the idea being that you in this room know what to do, and you've learned what to do for these patients, and I have no doubt that you're all amazing physicians and practitioners who are taking care of patients perfectly, but not everyone is, and what can we do to nudge providers to do the right thing? Some disclosures are up here. These are my learning objectives, and I do think I had too many slides, so what I decided to do is just give you the conclusion first, so that if I run out of time, we can stop. And after this slide, you can leave. This is all you actually need to know. So when we're talking about clinical decision support, the framework I like to use is what I call no care, act matter. The idea being that if you are going to tell a provider to do something like start an SGLT2 inhibitor in someone with chronic kidney disease, it won't work if the provider already knows that they're supposed to start an SGLT2 inhibitor in chronic kidney disease. You have to tell them something that surprises them a little bit. They also, and this is a tough one, they have to care. They have to, they might not know that they're supposed to, they have to decide that this is their job. And we've had some studies which are really interesting where we get feedback from providers. Have a lipid study, for example, where where we recommended up titration of lipid therapy. A primary care provider said, this isn't my role, I'll defer to cardiology. And that patient's cardiologist gave us feedback that this is not my role, we'll defer to primary care, right? So there's that disconnect as well. Let's say they care, they have to have a specific action. So, and I'll give you some examples of how just informing people of a problem might not be enough to move the needle. And then this is the kicker. You've got to show that the action you're giving them to take will change outcomes, will matter for the patient. And I think in the case of CKD and diabetic CKD, we can satisfy those 4 check boxes. But I'm going to tell you how we came to this conclusion now that we're done. I'm going to start over, how we came to this conclusion through a variety of studies of clinical decision support, not entirely in diabetic kidney disease. So as I said, I'm an AKI researcher. I don't have to tell you that AKI is bad, but I do like to remind people that it's common and carries with it a 10% inpatient mortality. Some of our older studies suggested that there was a problem with recognition, that providers didn't know their patient had AKI. I'll direct you to the pie charts. I teach my students never to use pie charts, but here we are. So for example, if we looked at patients with acute kidney injury who were receiving NSAIDs in the hospital, within the 24 hours after AKI developed, 41% got at least one further dose of NSAID, right? So one more dose of ketorolac after the creatinine had already started going up. That seemed pretty high and suggests that providers might not know their patients have AKI, because after all, you've got to do a little bit of math to figure out that the creatinine has changed. So we asked whether clinical decision support would work in this very discrete case. Can we just tell a provider that the patient has AKI and make a difference? And we built a little system that looks like this. You'll recognize the color scheme if you're at an Epic institution, not my choice. What you can see is kind of standard clinical decision support. Alert here, it gives some information about the patient, in this case, their creatinine values, and that's it. It's just telling the provider, hey, your patient has AKI, and at this point, we thought, we'll just let them know and then they will do the right thing. They don't necessarily do the right thing. In fact, we got unexpected results from this randomized trial. Our composite outcome, if you look on the far right, do you see my mouse? No. If you look on the far right, you can see that a composite of progression of AKI, dialysis, or death was actually higher in the alert group than the usual care group within our non-teaching hospitals. This was a pre-specified subgroup analysis. So a concerning signal of harm from telling providers that their patient has AKI. And it would be a whole other talk to explain exactly what's going on here, but I keep it in to remind people, this trial was called ALIA 1, to remind people that you really should consider randomized trials of interventions of these types, because even if it seems commonsensical, like of course you should tell providers that their patients have AKI. You may be wrong. Maybe you distract them from other things that are more important. Maybe you keep a patient in the hospital longer than they should and they get a iatrogenic infection. Maybe you convince a provider to flood someone with fluids who shouldn't have gotten fluids, and so on and so forth. So be careful for common sense interventions. So we, satisfied with that trial, checkbox 1, we thought, okay, providers didn't know their patient had AKI, so alerts could work, but then you have to make sure that they care, we believe that providers care, and you have to give them something to do. This was inspired a bit by one of our colleagues from the UK, Nick Selby, who did a step wedge randomized trial, again of AKI alerts, but this he coupled to a checklist, a standard set of interventions for AKI. So now not just telling the provider, hey, your patient has AKI, but your patient has AKI and you should do this set of things about it. And the checklist was common sense stuff, review medications, assess fluid status, obtain a urinalysis, consider renal imaging. And you can see that all those process measures like getting a urinalysis increased in the intervention group, although broadly speaking, clinical outcomes were not changed. But this led to us thinking, okay, we need to tell providers what to do. We can't assume that everyone knows what to do. And I think the analogy here is obvious. You wouldn't just say to a provider, hey, did you notice this patient has albuminuria? Just telling you. Or did you notice this patient has CKD stage 4? Just telling you. You would say, and they seem to be eligible for an SGLT2 inhibitor, and they seem to be eligible for a GLP-1 receptor agonist. To demonstrate how we use those kind of prompts, I'll tell you about a study in heart failure. Back in the day when we were designing some of these studies, we had very clear guideline-directed medical therapy for patients with heart failure and reduced ejection fraction, and we didn't for chronic kidney disease, and now we do, and it's very exciting. But basically, for the non-cardiologists, heart failure with reduced ejection fraction is very common. About 6 million people in the United States suffer from this condition, and there are 4 pillars of guideline-directed medical therapy for HFrEF. You will recognize them as being quite similar to the 4 pillars of guideline-directed medical therapy for chronic kidney disease, with a singular exception really in terms of beta blockers. So GDMT guideline is beta blocker, ACE/ARB, ARNI, mineralocorticoid antagonist, and an SGLT2 inhibitor. Stay tuned for GLP-1s. And this alert, similar to the last one, we give some patient information, but now we're giving you specific actions. We're saying, here are the 4 pillars, here's what they're already on, here's what they're not on, we put it in red, and we allow you to open an order set directly from there that will allow you to order the guideline recommended medications. I don't love having 2 clicks. Nowadays, we can actually get that built into the original alert itself, but at this point, we're giving you a very strict action to take. How did we do a study like this? This is a cluster randomized trial. We took 100 providers within our health system. In fact, we took every provider within our health system, and then we ranked them in terms of how many patients with heart failure and reduced ejection fraction they see in a year. And then we took the top 100 and started asking them to consent to this trial. And I think we got down to about 150 before we had 100 providers saturated. So 50 of those providers got alerts and 50 got usual care. All told, we had about 1,300 patients in this trial, recruited fairly quickly. That doesn't matter, but I'll show you our baseline characteristics here. One of the nice things about recruiting for studies in New Haven, Connecticut is the demographics of our city and that part of the state mirror quite nicely the overall demographics in the United States. So it's really interesting. If you look at national cohorts of HFrEF and New Haven cohorts of HFrEF, the numbers are very similar. We just happen to be kind of in the middle of the pack in many ways. But what we do pretty well on, at least in our system, is getting people on guideline-directed medical therapy. We had 85% on beta blockers and 70% of these patients on ACE/ARB ARNIs, less on MRAs, and these SGLT2 inhibitor numbers are somewhat unreliable because this was done several years ago, and the use of SGLT2 inhibitors has just skyrocketed over the past 3 years. So this doesn't look good by current standards, but it was pretty good back then. And our primary outcome was just an increase in guideline-directed medical therapy at 30 days. So a pretty short time horizon between the visit and did you get on an additional therapy. And we were able to show that there was a statistically significant increase, 19% of people in the control group versus 26% of people in the alert group had an up-titration of guideline-directed medical therapy. So a couple of things here. Number one, this worked to do what we wanted to do. We wanted to increase the rate at which people prescribe these medications. So that's good. P-value less than 0.05, we're always happy about that in the clinical trial realm. But then there's some concerns, right? Why 26%? Why not 90%? Why not 100%? When we talk to providers about this, we get a lot of similar responses. This wasn't the right time. There's just, there's other stuff going on. I was dealing with other things. I'll deal with this in the future. And to be fair, when we looked out at 6-month outcomes, this difference persisted and was still statistically significant, and kind of both groups had increased. So if we give providers more time, they do get on board. But in terms of getting right on board, there's that. There's the concern about false positives. So actually, I don't think my patient has HFrEF. This is something we work very hard to get rid of in the testing stages, because once you alert a provider, if you say, hey, this patient has CKD stage 4 and would benefit from a SGLT2 inhibitor, and they say, oh, no, they don't. They have an eGFR of 95 and they're perfectly healthy. The trust is gone. They're not going to believe anything else you say. So we do worry a lot about false positives. Sometimes we're actually correct, and the patient really does have HFrEF, and the provider didn't know, but that is an issue. And then there's good old-fashioned clinical inertia. Sylvia used the word inertia in her conclusion, which is, I think, what we're all fighting against. But it's this phenomenon where when a patient is sitting in the office and they're doing fine, the blood pressure's okay, they feel fine, they've gone on vacations, work is good, most of us don't do anything. We just say, okay, we'll see you in 6 months, we'll see you in a year. But what we're learning from all of these trials is that that's probably incorrect. We should not be reactive to high blood pressure to add a blood pressure medication like an SGLT2 inhibitor, if you want to consider it a blood pressure medication. In the case of heart failure, in the case of chronic kidney disease, we should be up titrating. We should be getting people on these domains of therapy, and it requires a paradigm shift. Okay, so we showed that alerts tied to guideline-directed actions can improve process outcomes, so we can get people on the drugs. And I'm glad I got to go last today to say, here's a potential answer for how we implement the great work that was presented earlier. How does that look in AKI? Well, in acute kidney injury, we had to ask that question, okay, what are we supposed to tell providers to do if the patient has AKI? And the answer was, gosh, it depends, right? There's a lot of different things you can tell a provider to do if a patient has AKI. Maybe you should give fluid, maybe you should give less fluid, maybe you should give diuretics, maybe you should, and so on and so forth. To target this to a narrow population, we said, well, at least we know that there are certain drugs that they shouldn't be on, like NSAIDs. So let's just find patients with AKI who are on a medication we don't like, and we'll tell the provider to stop the medication we don't like. So very discrete concept here. These are the medications we don't like. And I'm not sure if my poll is going to work. We picked these 3 classes. These are not all the nephrotoxic medications in the world by any stretch, but we picked these 3 classes specifically because of the way they're used in the hospital. So NSAIDs, we are quite confident are not good to give to a patient with acute kidney injury, and most providers seem to understand that and will discontinue NSAIDs. Renin-angiotensin system inhibitors, we're not entirely sure if you should stop those in patients with acute kidney injury, particularly if they're not hypotensive, but they're still discontinued by providers from time to time. And so we thought this was an interesting area to study in the context of a randomized trial. And then proton pump inhibitors, no one thinks about stopping during acute kidney injury except our group, who has a particular fascination with subclinical acute interstitial nephritis. So this was our, high risk, high reward group that we had chosen. I wanted to ask people, will this work? No.
Probably not.
Doesn't work? Okay. I was told to make a live poll. So I wanted to ask how many people in this room stop these particular medications in the setting of AKI, and I don't know, but you can answer for yourself, and I suspect most of you would stop the ketorolac, and some of you would stop the lisinopril, and most of you would not stop the omeprazole. This was a parallel group randomized controlled trial, randomized at the level of the individual. About 5,000 patients were randomized, and you can see that the inclusion criteria are pretty broad here. You just had to be an inpatient adult with stage 1 or higher AKI and an order for one of these medications that we didn't like with limited exclusion criteria. So highly pragmatic clinical trial. The primary process outcome was cessation of at least one of the medications that the patient was on, with a clinical outcome, primary clinical outcome being progression of AKI, dialysis, or death. You can see some secondary outcomes here, and we had some safety markers that we looked at, like we didn't want people to exchange opioids for NSAIDs, for example. This is what an AKI population looks like in our health system. which I think is pretty standard across the board, about 20% in the ICU, lots of heart failure and diabetes. And if you're curious about the medications of interest, the Venn diagram is probably the most appropriate way to think about this. The majority of patients were on PPIs. Some patients are on NSAIDs, some patients are on renin-angiotensin system inhibitors, and there's quite a bit of overlap there. When we look at the process outcome, once again, if you look overall, we show you that we can increase the rate of cessation by about 10%. So a modest effect by telling people your patient has AKI and they're on an NSAID, please stop the NSAID. In fact, in terms of NSAIDs, we didn't even get statistical significance. Now, part of this is because the absolute rate of cessation was quite high. We were getting, even in the control group, 85% or so cessation of NSAIDs. In part, probably because of our prior studies where we told people that they weren't stopping NSAIDs as much, and all the pharmacists got on board and have been convincing everyone to stop NSAIDs. But we saw a fairly impressive increase in the cessation of proton pump inhibitor, 26% increase. And I think the lesson here is that the more surprising an alert is, the greater the effect it will have, right? No one's surprised anymore when you say, this patient has AKI, please stop the Toradol, but they are surprised if you say, this patient has AKI, please stop the omeprazole. And so you get a larger effect size there. In terms of clinical outcomes overall, so this is, again, progression of AKI, dialysis, or death, about an 8% not statistically significant reduction in the alert versus the usual care arm, but in pre-specified subgroup analyses, a significant decrease among the patients receiving proton pump inhibitors. So sort of fascinating. For those of you who are interested in the ACE-ARB like I was, zero effect, convincing me once again that we might not need to stop ACE-ARBs in AKI. But it might be a good idea to think more about stopping proton pump inhibitors, at least in some patients. Secondary clinical outcomes here, nothing really worth mentioning in detail, and there are no safety signals. Why might alerts benefit people on PPIs? Well, we know that was the group that had the highest rate of discontinuation, and so we think the mechanism of the alert is supposed to be alert to discontinuation to improved clinical outcomes. It may be that PPIs are directly causing AKIs. It may be that PPI use flags individuals with a different risk profile, and I'll show you data in the next slide to suggest that. And of course, this is a subgroup of analysis, so this could be alpha error, right? This could just be, chance finding. But PPI users are different. So when we looked at the 60% of people in our trial who were receiving PPIs, you can see that they were less likely to be Black, they were more likely to have a medical admission, much more likely to be in the intensive care unit, more likely to have heart failure, slightly higher creatinines at admission and randomization, and a higher SOFA, so sicker. So PPI use also just kind of tags people for having more comorbidities, being sicker, and it may be that acute kidney injury alerts in general just work better on people who are at higher risk, not that it's specifically the PPI. So now we've learned that we can tell people what to do, we can get them to stop medication, albeit maybe not at rates that we would like to, but we aren't seeing that these actions that we're giving matter, that step forward. We want to improve clinical outcomes, except maybe in PPIs. So how customized can we get with this? We hypothesize that acute kidney injury is heterogeneous. It's not always the NSAID. There's a million things that can cause it. How can we tell people what to do in a more customized way? And so we ran the Kidney Action Team trial. These are members of the Kidney Action Team, which I'll explain very quickly. So we identified people with, again, KDIGO stage 1 inpatient acute kidney injury criteria. An alert was generated, but it didn't go to the floor team. It went to the Kidney Action Team. The Kidney Action Team is, at any given time, a pharmacist and a nephrologist. So it's 2 people. It's not a big team, but it's 2 people, but it might be different 2 people at any given time of day. They get the alert, they review the chart, they do some exclusions that the alert might not pick up on, make sure they're eligible appropriately. And then they create recommendations, and I'll show you how the recommendations work in a second, but very structured recommendations across multiple domains. So as opposed to a checklist where everyone gets the same checklist, this is a customized checklist just for your patient. Once they make the recommendations, then the patient's randomized. So there's no gaming the system here. They don't know if this is an intervention patient or a control patient. They make the recommendations first, they get logged in the system, then randomization happens. In the intervention group, a note is generated. I'll show you what it looks like. And in the usual care group, no note is generated. Those recommendations just live on the server until we decide to analyze them later. And this is what the system looks like. I'm not sure if this will work. Seeing if I can get this video to work. There we go. So what you can see here is a provider, a member of the kidney action team, clicking off specific recommendations. They're saying, oh yeah, I've got some recommendations here for fluid resuscitation or whatever, and acid base, potassium, whether the patient needs an urgent renal consult, and so on and so forth. So it's really just they're reviewing the chart remotely, and they're clicking. And then these recommendations become a structured note that goes into the chart. And the note looks the same for every patient except those checkboxes. So it's like, for this patient, this is what we want you to do. So as customized as we can possibly make it. We randomized 4,000 people across 2 health systems. This is Yale and Johns Hopkins, about 2,000 to each group. And again, baseline characteristics pretty similar to our prior studies of AKI patients. The average number of recommendations per patient was just three things that we think you should do right now at the start of AKI, and we were able to get those recommendations made within 56 minutes, a median of 56 minutes of the lab result that defined AKI coming in, so it's pretty efficient. A total of 14,539 discrete recommendations made across the trial. And you can see the categories here. So almost everyone gets a recommendation in the diagnosis stuff, right? Check a urinalysis. Not as much potassium acid base or renal consult. People who don't have potassium problems tend to not get potassium recommendations. But really interesting, 55% got at least one medication recommendation. So these are patients with mild AKI, stage 1, and more than half have a medication that should be dose adjusted or stopped or something else, which was really fascinating. And if we look at our process outcomes, once again, you see this kind of difference that I've shown you before, which is that in the usual care group, 24% of the things we thought the provider should do, but we didn't tell them, they did anyway. So this is the baseline rate of following instructions. That increased to 34%, about a 10% difference in the intervention group. So that's highly statistically significant, but again, it's not everything. When you look across the various domains of recommendation, you can see that in some places we nearly double the rate at which recommendations are followed, like diagnostic tests and medication adherence, medication changes, but we had basically no effect on volume, potassium, or acid base. I'm not particularly surprised about volume. We were remote, so we were trying to gauge volume status based on somewhat indirect measures without being able to examine the patient. If you're curious about specific recommendations, here's a sampling of what it looks like. So if we tell you to get a urinalysis, you're more likely to get a urinalysis. If you want a protein to creatinine ratio, you're more likely to get a protein to creatinine ratio, CK, renal ultrasound, bladder scan, and so forth. The primary outcome was a composite of AKI progression, dialysis, or death. No difference. So 20-ish, 21% in both groups. So we're able to evaluate patients quite quickly. If I tie this into our other studies, right, we can do this with humans pretty efficiently. We can do it with algorithms even more efficiently, although with less individualization. Basically, every patient has something you can do for them. We can increase the rate at which providers do the thing, but we still haven't demonstrated that we change clinical outcomes. So here's the end. We already talked about this. So what do we do going forward? We recognize that there's a problem. Providers need to be made aware, or potentially need to be made aware, that there's guideline-directed medical therapy for CKD and for CKD with diabetes. Let's take it on faith that many of our providers would care about this if they knew about it. Let's believe that. We have a very specific action to be taken. And in the randomized trial framework, we know that things like SGLT2 inhibitors and GLP-1 receptor agonists do improve outcomes. So those changes would matter, but I will caution people that that doesn't mean that a clinical decision support system to increase the use of these things will also translate to clinical outcomes. That disconnect arises from two places, and then I'm done. The two places are, number one, in a randomized trial, 100% of people in the intervention arm get the drug, more or less, and 0% in the control arm. In a clinical decision support trial, something way less than 100% of people in the intervention arm get the drug, and something way more than 0% of people in the control arm get the drug. So the effect size needs to be a lot bigger to see a difference. So that's just something to be aware of. You might not want to be so disappointed if your clinical decision support system doesn't reduce the rate of dialysis, because there's so much mixing of patient populations there. The other thing that's harder to prove, but I do think about, is it's possible that the marginal person who moves from not being treated to being treated in the context of clinical decision support are the low-hanging fruit people, the people for whom it's easy to add a medication on. They're a good patient, they have good insurance, they aren't taking too many other medications already, they're very knowledgeable, they're happy to do it, and so on and so forth. And it might be that those patients don't benefit that much because they're already going to do fine. And so that's another area where I think we need to kind of explore this deeper. So a lot of work to do, but hopefully I've gotten you interested in what to do about it. Thanks.
Thank you, Dr. Wilson. That was excellent. Anybody have any questions? Please step up.
Hi, Perry. Great talk. Thanks for educating us about this. I was just wondering the logistics around creating these alerts. Like, how did you manage to get Epic to create these alerts in your system? Because I think if we all know this, I think it'll help a lot of people. As you mentioned, the number of patients who are getting SGL2 are like 5-6%. I mean, if there was a way that everybody could get the alert, would be great.
So a lot of different ways. First of all, this is becoming easier and easier. So Epic is our system, and with every upgrade, they're improving. This is called, they call it BPA, Best Practice Alerting System. You can get trained as a physician. You can take classes to learn how to become a physician builder in this, although full disclosure, I have a professional medical informaticist in our lab that does all of this work. But you should know that Epic has a program called Turbocharger. So if an Epic institution builds an alert and you like it and it's good, we can export it, it comes as an XML file, to your institution, and your Epic team can import it and have it there. It requires a few things to plug in, but it has made the implementation of multi-center studies much, much easier for us. We're doing that in heart failure right now.
One follow-up question.
Yeah.
How do you deal with alert fatigue? My worry is like there's so many alerts coming in, and I think people ignore them.
Yeah. Oh, it's a huge problem. So number one, you should be doing trials of your alerts. And I'll tell physicians, I'll say, look, we're going to do a trial. If it doesn't improve outcomes, we'll stop. And then they sort of get behind it. The problem is that you have a lot of other generally well-meaning people who are building alerts into the system without that. So I think it's cultural. We have to start demanding that even like alerts that seem common sense, and I cite my own AKI trial. I'm like, of course, we all think this would be a good idea. It turns out it's not a good idea. Please do some A/B testing. A/B testing sounds better to informatics people than randomized trials, but it's the same thing. I think we also need to work on the regulatory infrastructure of hospitalization and consent to allow for more of these trials to actually happen. I always tell people you're in the middle of 8 million trials every time you flick through Facebook, because they're A/B testing every different format and whatnot. And we need to start being able to do that kind of thing for minimal risk trials in the hospital.
One more question?
Hello, Amanda Martinez, clinical pharmacist. First, thank you for looking at PPIs. Love discontinuing those. Secondly, do you look at in any of your studies differences based on the level of training for the people that are receiving these alerts? So residents versus fellows versus an attending, and then looking at the seniority of the attending. We have, and we've looked at MDs versus APRNs and PAs and things. And to be honest, the adherence rates, we've never shown a terribly impressive difference. So
everyone kind of gets notched up a little bit, but it's not like the very, very senior attendings ignore them more than the interns, which is what we would have hypothesized, but we just don't see that.
Great. Please
Thanks.
join us in thanking all of our speakers.